Thanks very much. Delighted to be here. Wonderful meeting and wonderful place to have the meeting. So I am going to talk about better evidence for the pandemic management, EBM, and the role of randomized trials. And in terms of this talk, I'm going to give some background to how this talk happened. I'm going to give a capsule history of EBM, talk about the need for randomized trials, need for systematic reviews, talk about a third principle of evidence-based medicine, which is that evidence is never enough to make decisions, and then mention the dearth of pandemic RCTs in population health. So a few months ago, quite a few months ago, Atla wrote to me about this meeting and said, Gordon, would like you to come and speak to this meeting. And when he told me about what the meeting was about, the way he expressed it was about the use of cluster trials to explore issues in how we should manage pandemics at a population health level. I said, sorry, Atla, I cannot come. I am completely unqualified to talk about this. I've never done a cluster trial myself. I've never been involved in pandemic cluster trials. I really don't know very much about it. I'm kind of sympathetic to the idea, but that is it. I never did anything like the heroic efforts that Atla told us about this morning in trying to get these cluster trials going to address the pandemic issues. I am just totally not qualified. Atla replies to me, and he suggests a title to my talk. And the title he suggests is Evidence-Based Medicine, an Historical Outline of its Application in Clinical Medicine and its Potential in the Management of Pandemics. He acknowledged that his title was a little long, so I've chosen a slightly shorter title, but it basically captures Atla's title. But then something happened that has never happened to me before in my 40 years in academic medicine, and I don't expect it to ever happen again. Atla not only gave me the title of the talk, he gave a point form outline of the whole talk. Not only that, each of the points gave the number of minutes I should spend on that particular issue. And then I said, okay, Atla, if you want me to talk about that, I'm good at that. I can manage that. And so you are now about to hear Atla's talk. Okay, so how did EBM get started? In the 1960s, there was the thalidomide crisis. All these women had taken thalidomide during their pregnancy. The kids were born with these terrible limb deformities. And that somehow awoke the world to the need that there is some scrutiny and some regulation in how these drugs get out and they are used. And that started the FDA down the road of demanding randomized trials from people who want to have their drugs out in the public. Around the same time it got started what have been described as small variation studies. So people looked at communities that were similar communities close together, and in one of these communities, 10% of the kids had tonsillectomies, and in another, 60%. And hysterectomies, other surgical procedures, use of antibiotics was radically different, not only between different countries, but between different communities that seemed similar, that were close together. This obviously makes people think something is going wrong here, and it further makes you think, who's right? Is community A right in the way they do it, or is community B right in the way they do it? And how do we sort out who is right? This created somewhat of a crisis in credibility for medicine, and I'd like you to keep in mind when I talk about something that happened later, that this to me is part of the explanation for what happened later. Meanwhile, we're in a world that a lot of young folks cannot imagine what the world was like before EBM. We are in a world where there is zero attention, zero to have anybody with health sciences training, doctors, nurses, physios, whatever. No thought at all to help them learn to read the original medical literature. It was complete mystery to anybody getting health sciences training. And Dave Sackett said, no, clinicians should be able to read studies. They should be able to read methods and results. And implicitly, perhaps, the results of those studies should guide our clinical care. And he called this exercise of learning to read the literature critical appraisal. It was essentially, at the start, a classroom activity. And then Dave came up with a term, it was around the time he went to Oxford, bringing critical appraisal to the bedside. And what you now did is, you had a patient with a problem, you weren't sure how to solve the problem, and you said, okay, I'm going to go to the literature to solve the problem. This was never done. This was a completely new idea of starting with a problem and going to the literature to solve that problem. So, previously, how had people made these decisions? They had done it hugely on physiologic reasoning. They'd done it on their personal experience or other folks' experience, and the guidance from on high among experts. And now there was an alternative source of solving critical problems, which was identifying the problem, having a structured form, the PICO, Patient's Interventions, Comparator, and Outcome, going to the literature and then critically appraising it and then bringing it back to the patient. So in 1990, I took over the residency program, leading the residency program in internal medicine at McMaster University. And we had now been doing on the wards, applying this, starting with the patient, identifying the problem, structuring it, going to the literature, and it felt like a different way of practicing medicine. And so I said, I want to teach this new way of practicing medicine, which at that time it was McMaster University, and that was it, other than perhaps at Oxford where David got it started. And so I was going to do this, and I knew that not everybody would want to do it. There would be some residents or some prospective residents who would be attuned to this, and others would not. So I was going to say, come to McMaster to learn what exactly? I need a name for it. I just come to McMaster to learn what? Well, my first thought was scientific medicine, and as I was appointed, I sent a little prospectus out to all the people who were in the Department of Medicine and said what I wanted to do, including that we're going to call this scientific medicine. And then the Department of Medicine held an evening meeting, invited everybody out, and introduced me as the new director of the residency program. And the first guy who asked a question, I should say, these people in the Department of Medicine were all basic scientists. They weren't all basic scientists, but dominated by basic scientists who were serious basic scientists. And the first guy who asked the question was so angry, he was shaking. And the attacks just came. How dare you? We are the scientists. You call what you do. You do clinical epidemiology. We're the scientists. And at the end of 45 minutes of negotiating this and managing, I was told that the chair of medicine started to rise from his seat 3 times and say, stop, stop, the attack has to stop. But each time I somehow managed to negotiate it enough that he sat down again. But at the end of it, it was clear scientific medicine was not going to cut it. I had to come up with something else. And the something else was evidence-based medicine, which turned out to be very catchy. And here is the first paper that was alluded to in the introduction a minute ago, the first time that the term evidence-based medicine appeared in the scientific literature. And to give you an idea of just how long ago that was what I looked like when that paper was published. All right, so here's the paper. We were not modest. We said this is a new approach to teaching the practice of medicine. And we alluded to Thomas Kuhn's scientific paradigms. Examples of Thomas Kuhn's scientific paradigms, moving from Newtonian physics to quantum physics, moving from the way we thought about human beings before Freud and the way we thought about human beings after Freud. And I said, here's another one, moving to how we used to do medicine to how we're using to do medicine now. We were not modest. Okay, so there it appeared. It described how we used to do things. I've told you the emphasis on physiology, on personal experience, on expert pronouncements, and now this different way of doing it. And now we say, okay, clinicians are going to have to use they're going to look at the literature. We have to tell them how to use the literature, because there was nothing really out there. There was what classical epidemiologists had written, which was not going to work. So what we did, and what made a huge difference, the first article published in JAMA. JAMA is the world's largest circulation journal, so they published it. So they published the first article, and then they published this series. And between 1993 and the year 2000, we published 25 papers describing the user's guide to the medical literature, which gave the guide that that clinicians should use. And you see there the key ones were therapy, diagnosis, harm, prognosis, overviews, which we called overviews. They've subsequently become systematic reviews, decision analysis guidelines, and some secondary ones. So by 2000, we had 25 papers that were guides. And this then was adopted certainly throughout North America as the curriculum for evidence-based medicine. And by the year, the uptake of this was extraordinarily rapid. 2 years after this, the landmark paper introducing it appeared, I received a promotional material from the American College of Physicians talking about it started in this era of evidence-based medicine. 2 years after the thing comes out, extraordinarily rapid uptake. And here I want you to think back on those small area variation studies. They had really shaken things up, and people needed a way to say, okay, which of these, when these communities do different things, how do we decide what is the right thing to do? And this EBM provided a solution to that problem. All right, but we still need, here's how to read this article, that article, the other article. We still actually need something of a hierarchy of evidence. And I'm going to show you a couple of problems, and I'm going to want you to address the problem. Consider the following. Children with infantile colic, almost 70% improve after spinal manipulation. Conclusion, spinal manipulation improves infantile colic, right? What's wrong with the reasoning? Somebody shout out, please. What's wrong? Cause and effect. Oh, I'm sure you're right. That's not a great explanation. No control group. That's absolutely right. So the problem is 69.9% of the infants without the spinal manipulation improved. They were destined to improve anyway. That was a natural history issue. Okay, here's another one. And this is quite real. Autism typically diagnosed in the first 3 years of life. 99.5% of children diagnosed with autism have no vaccination. Conclusion, vaccination causes autism. What's wrong with that? Yeah, you like saying causation versus association. No fancy explanations, okay? You're talking to the lay public. What's wrong with this? Because the lay public is subjected to this. Tell the lay public what's wrong with it. If A is followed by B, no, come on, simple. Okay, here's my answer. 99.5% of children without autism had vaccination, okay? That's the explanation. The rate of vaccination is the same on those without. Your answer of you need a control group would have also provided fine. Okay, now, I told you that physiologic reasoning was seen as completely legitimate in the way of solving problems. We still pay too much attention to it, in my view. However, some examples. Antiarrhythmic drugs, flecainide and kainide. People after myocardial infarction are subject to lethal arrhythmias. Nasty, it kills them, ventricular arrhythmias. These drugs obliterated, they were amazing. They obliterated all these warning arrhythmias. And the cardiologists were so impressed at this, they persuaded the FDA to license the drugs without any randomized trials looking at patient-important outcomes. Fortunately, they did the trials belatedly after it was licensed, but they did the trials, and it turns out these wonderful antiarrhythmic drugs increase arrhythmic deaths. Not only do they not have an effect, they actually increase arrhythmic deaths. And it's estimated that because they put them out before they did the trials, more Americans died from taking these drugs than died in Vietnam. Okay, these drugs listed there are vasodilators and inotropes. And we know in patients with heart failure that if you improve the cardiac output, people get better. And if you take the afterload that the heart pumps against and you put it down and the heart gets unloaded, heart loves it, and things go very well. All these drugs decrease afterload and increase inotropy, the heart's ability to pump. When tested in randomized trials, with the anticipated decreased mortality did not occur, and instead mortality increased. So, patients at risk of cardiovascular disease. So we've talked about physiologic reasoning. The basic science folks and many clinicians trained in those traditions love surrogate outcomes. So consider a particular surrogate, high-density lipoprotein. We all know who works in medicine that high-density lipoproteins are associated with lower cardiovascular risk, and the physiologists think they understand why this happens. So, obviously, interventions that raise the HDL should lower cardiovascular risk. It follows logically that that's what should happen. So, people fortunately decide to test it out. So they give niacin to a population, they do a big randomized trial, raises the HDL nicely, but sorry, no reduction in cardiovascular risk. So the physiologists and their associated clinical trials think, well, what's wrong? Well, what they thought was people weren't taking their niacin as well as they should, and we didn't have enough patients to show the effect. So they next do a trial where they do a run-in where everybody takes niacin. If you don't tolerate niacin, you stop, you get out of the trial. And they do a compliance-enhancing drug as well. So you're now going to have everybody take their niacin, and you're going to have over 25,000 patients. You're going to have enough patients to show the effect. Okay, and the HDL did go up nicely, and the LDL went down on top of that. Major vascular events, slight trend in the right direction, but the confidence interval includes a 3% increase in their outcome of interest, and with 25,000 patients, they've been unable to show an effect. However, with 25,000 patients, they were able to show all the adverse effects with niacin, which hadn't been suspected. Increase in diabetes, increase in GI serious effects, musculoskeletal, infection, bleeding, all p-values of less than 1 in 1,000. That's what they showed, all the nasty things that niacin can do that they didn't suspect. Okay, so much for niacin. But why? We're raising the HDL. Things are not getting better the way they should. What's the explanation? What can we do now? Okay, so what we do, niacin effect is too small. So let's get something really potent to raise the HDL. So they're raising these cholesterol ester transferase. Anyway, fancy drugs, the beautiful drugs. They raise the HDL very nicely. Big effects. And they lower the LDL, which is the other thing, high LDL associated with cardiovascular risk. So off they go. They use this randomized trial of torcetrapib. And at 12 months in patients who received the drug, there was an increase of 72% in HDL and a decrease of almost 25% in the LDL. P less than 1 in 1,000 for both comparisons. Unfortunately, there was an increased risk of cardiovascular events, hazard ratio in a 25% increase, p-value highly significant, and an increase in all-cause mortality. It killed people. It actually killed people. You see the p-value. Okay. These physiologists, they didn't seem to understand things as well as you might have. And they said, okay, what has gone wrong? What has gone wrong? Okay, well, what has gone wrong is, as it turns out, when we think about it, after having observed that it kills people, we find out that it increased blood pressure and increased aldosterone. So let's get a new one of these drugs that doesn't increase blood pressure and doesn't increase aldosterone. And it has and also creates the big HDL and decrease in the LDL. So they get another one, 12,000 patients. primary composite outcome related to cardiovascular disease, big increase in HDL as anticipated, substantial decrease in LDL as anticipated, and still no effect. And they still haven't figured out this one why. So think of the attachment to the surrogate outcomes. If it doesn't happen in one, we must have it right. Just get solution after solution after solution. And the problem is they never understood it from the beginning. And we still don't understand it. All right. So we've talked about surrogate outcomes. Now let's go back and talk about another problem. So the other problem, consider the following. 100,000 people hospitalized, followed for 3 months, 40 die. 1,000 people in the community followed for 3 months, 2 die. Dying is 20 times more likely in hospital. Obviously, hospitals kill people, and if we only avoid hospitals, we'll live longer, right? Okay, what's wrong now? What's the problem? I use this in the general public. When I talk to the general public and I explain EBM, this is what I use, okay? So now explain to the general public what is wrong with the reasoning here. The general public, by the way, I use this one, they intuitively realize that something's wrong here, okay? But what's wrong? To explain, what do you say to the general public of what's wrong here? Sorry? Selection. Okay, come on. Cut the technical language, okay? Tell an ordinary member of the general public what's wrong. They're not comparable groups. Thank you. They're not comparable groups. In other words, to put it simply, the people in hospital are different from the people in their not hospital. And the reason everybody gets it is they know the people in the hospital are sick and the people in the community are non-sick. But as soon as you move out of this extreme example, people stop getting it. The intuitive realization that the people exposed might be different from the people unexposed tends to disappear. And you have to keep reminding people of this, or I find I do anyway. Okay, so let's say you did this study. Obviously, it's a silly study, but say you did the study and you see the problem. What can you do to try and get at the truth, which is it's not being in hospital, it's the problem, it's that the people are different. What can you do? And here I'm going to allow you to use a technical term. What's the technical term for what you do to address this problem? Well, you could do an RCT, but no, you've done the observational study, and now you want to, there's two possibilities. Hospital kill people, or it's the people are different. How are we going to sort out the difference? Come on. Adjusted analysis. We do an adjusted analysis. That's how we sort out what's different. Okay, so adjusted analysis. What is optimal adjustment? Well, you've got to accurately measure all these prognostic factors. For instance, we know that one of the most powerful determinants of prognosis, in a way maybe the most powerful, is socioeconomic status, and the people, tobacco and alcohol. And now you have to document these accurately. Maybe not that easily. So then you have to adjust for all the prognostic factors. So you have to identify all the prognostic factors, you have to measure them accurately, and then you have to do the appropriate adjusted analysis. Unfortunately, you do all this and you've still got a problem, and what we call the problem residual confounding. After all the adjustment, people are still different in ways that we don't understand well. And that's why you need randomized trials. And people have generally accepted that. Except there's always been pushback from communities that are enthusiastic about observational non-randomized studies, and the pushback continues. And now the people who push back against randomized trials have got a great weapon. They've got a wonderful weapon that they've used. It's very smart, quite brilliant. They call what they do real-world evidence. And now, if you were someone, do you want this fairyland of RCTs, or do you want real-world evidence? Take your choice, okay? Obviously, we will want real-world evidence. Now, what do people mean by the real-world evidence? To a very large extent, one of the people used it in different ways, but perhaps the number one way it's used is looking at administrative data. So you go to administrative data, tells you what's happening in the real world, and you look at the people who received or didn't receive the intervention out in the real world as captured by the administrative data. What are the concerns about administrative data? Well, one of the concerns is you can't trust the administrative data. And so there have been a whole bunch of studies that say what you get out of the administrative study. Remember, we said that if you want to do your adjustment, you've got to accurately measure the prognostic factors. If you don't accurately measure them, forget it. So you have one study after another study, after another studies that document the problems. Here's one, report cards for hospital-acquired pressure ulcers. Hospital performance score generated from these rates varied considerably according to whether administrative or surveillance data, suggesting that administrative data may not be appropriate. Another one, regional variance in diagnostic, they use people's diagnoses to adjust. So, and they use it across regions to figure out what's going on. Substantial difference in diagnostic practices that are unlikely to be related to patient characteristics are observed across U.S. regions. The use of clinical or claims data for adjustment includes important biases, and so you can't trust the results. So this paper gets written. Administrative database results has unique characteristics that could risk biased results. What are these unique characteristics? These unique characteristics is the things aren't accurate. That's the unique characteristics of these things. Okay, so here's what real world data relies on. They don't even measure the prognostic factors properly to even do the adjustment. Hopeless. Okay, so other examples of non-randomized trials gone wrong. People with high level of antioxidant consumption. They get that their diet has great levels of antioxidants. People who have these diets with great levels of antioxidants have lower cardiovascular risk and lower cancer risk. And they do. You take antioxidant vitamins, we go out in antioxidant vitamins, we're going to have lower risk of cardiovascular risk and cancer. Unfortunately, it has nothing to do with the antioxidant vitamins. When people do the randomized trial of antioxidant vitamins versus nothing. Hormone replacement therapy, a famous one if you've been alive long enough, everybody was saying and persuading all the primary care physicians to tell all their women to use, all their postmenopausal women to use hormone replacement therapy to lower their cardiovascular risk. Sorry, doesn't work. Beta blockers, the observational studies showed reductions in mortality. Sorry, when we do the randomized trials, doesn't work. Hydroxychloroquine going to COVID, observational studies suggest they're beneficial, they are not. But then, what do the defenders of observational studies say? They look and they say, and the well-done observational studies, and they compare in the randomized trials. And they say, most of the time when the observational study is well done, the randomized trials give similar results. And they are absolutely right. The trouble is, until you do the randomized trial, you don't know whether it was one of the situations where it's getting it right or one of the situations where it's getting it wrong. Sorry, you still have to do the randomized trials, or otherwise, if you take it, you're going to have lots of situations where you're making the incorrect inferences. All right, so all of this leads to the first simple hierarchy of evidence that Dave Sackett and others generated. It acknowledges that our clinicians, if we are clinicians, our clinical experience is a legitimate source of evidence, and it is. Unfortunately, it's very subjective and it's often wrong. Basic research can be compelling. You've heard the stories of how basic research and reliance on surrogate outcomes that flow from the basic research, how wrong they can be. Observational studies, real-world evidence, or better than real-world evidence because they actually collect the data and get to measure the prognostic factors accurately, is the problem of non-comparable groups. And so that's why randomized trials are at the top of the hierarchy. But this is too simple a hierarchy, and we recognized it was too simple a hierarchy. We had to come up with something more sophisticated. And what we came up with that was more sophisticated is captured in the GRADE approach to rating the certainty of the evidence and guidance for going from evidence to decisions. And again, this was the other hit. I've said a lot of things in my career, really good ideas that should have been taken up that were absolutely ignored. That's happened quite a few times. However, the first huge hit was EBM. The second big hit was GRADE. Really very impressive uptake over a relatively short period of time. And there are now over 120 organizations worldwide that use GRADE. So now we have a much more sophisticated hierarchy of evidence. On the right side of the slide, grade classifies the certainty or quality of the evidence as high, moderate, low, or very low. Randomized trials, we still like them. They start as high certainty evidence. But there are lots of reasons why they may not end up as high certainty evidence. They may have risk of bias problems. They may be unconcealed, unblinded, or lose large number of patients to follow-up. They may be small sample size, and so wide confidence intervals, they will be imprecise. They may have indirect evidence. I still practice as a secondary care hospital-based internist, and I look after lots of general medical patients, and lots of them are now over 80, and in the last 10 or 15 years, quite a few are now over 90. Well, there ain't too many people over 80 in those randomized trials, and there's very few people over 90. So can I be confident applying my randomized trials to my patients over 80 and over 90? Maybe not so much. The randomized trials in younger people yield indirect evidence for these very old people, and so we lose some degree of certainty or confidence. Inconsistent results and publication bias. So we have 5, and that was one of the big advances to me of grade. We came up with 5 categories of reasons why randomized trials may not yield high certainty evidence. And these problems also apply to observational studies. Observational studies which start as low certainty evidence can go down further to very low certainty evidence if they have these problems as well. However, observational studies, and this is a very important improvement in the hierarchy of evidence, sometimes observational studies can yield moderate or even high certainty evidence. How many people in this room look after patients? Part of your life is looking after patients. Okay, a third of the, almost a quarter to a third. Okay, can you guys, you women and men who look after patients, tell me something that you do in your clinical practice that you know helps patients, but no randomized trials. Despite the fact of no randomized trials, you know it. Who can tell me something? Antibiotics, yes. Sometimes we don't know which antibiotic to give or how long to give it, but we know antibiotics versus no antibiotics, improve patient outcomes. What else? Anybody else have another idea? Sorry? Epinephrine and anaphylactic shock. Excellent. Okay, I'll give you a few others. Resuscitation after cardiac arrest. Everybody used to die. Now some get through. Dialysis in people with terminal renal failure. Putting in intubation. We heard about prone ventilation earlier today. When prone ventilation fails, intubating people will make them live longer. Maybe not much longer sometimes, but make them live longer. And other interventions in the orthopedic area, hip replacement. I can tell you, I've had 2 of them. It makes a difference. Okay, so what do all these interventions that we just said have in common? What do they have in common? Large effect. Right. They all have very large effect. They have such large effects that nobody looking at the observational data would have any questions that these things work. So, large effects on the right side, the observational studies start as low, but they can go from moderate or even, in the examples I've used, to high certainty evidence. Despite no randomized trials, we have high certainty evidence for these things. So this is a much more sophisticated hierarchy, which it turns out has served us very well. Okay, next. This is a systematic review and meta-analysis of thrombolytic therapy after myocardial infarction. And it is not your usual forest plot. The reason it's not your usual forest plot is this is a cumulative meta-analysis. First trial had 23 patients. The second trial did not have 65 patients. It had 42. This is a cumulative of all the data. And what you see is that by the time you have 7 trials and under 2,000 patients, the confidence interval is still overlapping no effect. Thrombolytic therapy may be helpful, but it may still kill people. Well, by 2,500 patients, now we have the confidence interval does not overlap no effect, and we're getting into a respectable p-value. When was the answer in? When do we know with confidence that we could apply in clinical practice thrombolytic therapy? Well, we could have a discussion, but I think most of us, by 30 trials and over 6,000 patients, we have confidence interval a long way for no effect, and we have this very low p-value. Did this stop the clinical trialists from doing randomized trials of thrombolytic therapy? No, it didn't. And another 40,000 patients were enrolled after the answer was in, half of whom did not receive the life-prolonging benefits of thrombolytic therapy. Why was it that we had to enroll another 40,000 patients after the answer was in? I think the answer to that question is on the right side of this slide, which shows the recommendations that cardiology experts were making as these data accumulating in textbook and current review articles. And you see in the latter part of the 1980s that you have, first of all, you have wide expert disagreement. Some are saying, it's settled, give it to everybody. Some saying, oh, only for specific patients. Some calling it experimental, and some not even mentioning it. So wide disagreement among the cardiologists, and it's a decade after the answer was in that you're finally getting a consensus among the cardiology experts. And I've talked to the people who did some of these trials after the answer was in, and they said, we just got to keep doing trials until we finally convince these cardiologists that thrombolytic therapy is a good idea. Second story again from myocardial infarction. People after myocardial infarction are subject to lethal arrhythmias. We know that. Lidocaine, established as a good antiarrhythmic agent. Give the people the lidocaine and you'll prevent the lethal arrhythmias. Makes total sense. As it turns out, in this case, was there ever any randomized trial evidence supporting lidocaine? No, there wasn't. The point estimates in this cumulative meta-analysis are all on the harm side. And as a result, we never proved harm, but we certainly excluded benefit. Did that stop the experts from recommending lidocaine? No, it did not. And you can see most of the recommendations. And so 45 years ago, when I did a rotation through a coronary care unit in Toronto, every patient who came in the door, I started a intravenous infusion of lidocaine, what we called a lidocaine drip. And I was doing it, and I was harming my patients and with no benefit because of these recommendations. Okay, these are sad stories. They're the cardiologist experts a decade behind the evidence, and as a result, people having to do randomized trials, people not getting treatment, and people being given subject to harm with no benefit. Big problems. Now, they're old stories though. Experts still disagree. They sometimes get it wrong, but perhaps not as badly as these stories. Something happened in 1990 that changed the picture. What happened in 1990 that changed the picture? That experts still disagree. They still get it wrong, but not as badly as this. What happened in 1990 to make such disasters less likely? No? Of course you can guess. That's why I'm asking. I want you to guess.
I think you Lido, just push, not as a drug.
Sorry?
Like Lido was a push meant during like ventricular fibrillation or whatever. It was part of.
Well, we're doing it to prevent the VFib, but
Yeah. So that's
yeah, but in general.
Stop doing the drip.
Yeah, but in general, what changed in medicine? The big change in medicine that prevented, this could happen in these mistakes could happen in gastroenterology or allergy or anywhere. I've shown you ones in cardiology, but something changed to prevent the experts from having this wide disagreement, from being a decade behind the evidence, and from getting it dead wrong, so to speak. Yes, systematic reviews and meta-analysis. They weren't around before 1990. I'm sure if you asked a lot of young people, when did evidence-based medicine and systematic reviews start, they would say, 1850. But no, not 1850, 1990. And I would contend that if the experts had seen this, and if the experts had seen this, they would have got the message much early, and they would not have been recommending harmful therapies to people. And that the systematic reviews and meta-analyses have made, I think, a huge difference in preventing this sort of problem. And that brings us to the third principle of evidence-based medicine. This is P.J. Devereux, who is now changing the world with respect to perioperative management of patients and reducing cardiovascular risk. But as a resident before that, he did a study that I'm going to tell you about, and I'm going to replicate the study. And you are the participants in the latest replication of Dr. Devereux's study. Patients with atrial fibrillation are at risk of stroke. However, anticoagulation decreases stroke. Picture the following. In 100 patients, 12 will have a stroke in the next year, but anticoagulation is going to reduce it to 4. 8 fewer strokes, 4 major and 4 minor. And the question is, how many serious bleeds would you accept in 100 patients and still be willing to use anticoagulants? Now, I now realize I should have included Dr. Devereux showed his patients what it was like to have a stroke. He gave scenarios of a major stroke and a minor stroke and a gastrointestinal bleeds. And most of the time I give this to a medical audience who understand these terms. However, do your best. I'll do it very briefly. Minor stroke, you can't move an arm, you have a little problem speaking, you spend a few days in hospital, you're left with a little bit of weakness in your arm. It's not nice, you can't do all the things you used to, but basically you can live a normal life. Big stroke, you come in, you can't speak, but one side of your body is really weak, and you recover your speech to an extent, you recover your motor function, but essentially you're disabled. You need help for doing everything all your life, and that's the end of that. Major gastrointestinal bleed. You wake up one day, you're not feeling well. A little later in the day, you vomit blood, a lot of blood, terrifying. You run to the hospital. Doctor puts down a tube, maybe injects something to stop the bleeding in your intestine. You spend a few days in hospital. You go home, and a month later, you're feeling okay. All right, that's a stroke, and that's a big gastrointestinal bleed. All right, so question is, we're going to prevent 8 strokes in 100 people. How many gastrointestinal bleeds would you tolerate to, as a patient, receive the anticoagulation, or as a healthcare practitioner, offer it to your patients? Okay, who would tolerate 5 or fewer bleeds? If more than 5 bleeds, no thank you. Anybody that would tolerate 5 or fewer bleeds? Nobody. Who would tolerate up to 10 bleeds, but more than 10? Nah, not a good idea. Who would tolerate up to 10? Okay, we have a few people who tolerate up to 10. Once you voted, you can't vote again. Okay. Now, 15 bleeds. How would tolerate up to 15 bleeds and no more? Okay, now you've got a few more people. Who would tolerate up to 20 bleeds? Okay, again, quite a few more. Anybody tolerate more than 20 bleeds? Now, a lot of people still tolerate more than 20 bleeds. Okay, good. Okay, great. Here's what happened when Dr. Devereux asked his physicians in the bluish color, and you get a flat distribution, okay? So first of all, wide variation among the physicians, and they're pretty bleeding averse. Here we still got it from, we had a few people who didn't like more than 10. Quite a few people didn't like more than 15, and a lot of people didn't like more than 20. But the patients, 2/3 of them were ready to tolerate 22. 22 seems like an odd number. Where does 22 come from? When Dr. Devereux did this, he was thinking like a clinician. He didn't think they'd go over 22. Had you given them the chance, they would have. So, number one message, wide variation among the physicians the physicians in general are much more bleeding averse and much less stroke averse than are the patients, but wide variation so clearly if you're going to use average values and preferences, you should use those of the patients. However, there's another message in this. While overwhelmingly the patients are stroke averse, there are some at the other end, a few of them, that share the physician's values and preferences and are more bleeding averse. What does that tell us? It tells us that these differences in the way you value stroke and bleeding, which we call values and preferences, vary a lot among patients. And if you want to get it right, better to use average patient values than the physicians, but if you really want to get it right, you have to consider the individual patient values and preferences. Okay, so those are, we have the 3 principles of evidence-based medicine. Number 1, some evidence is more trustworthy than others, and we have a hierarchy to show you that. Second, we need systematic summaries of the best evidence to get it right. And thirdly, a little bit of an ironic principle perhaps, evidence never tells you what to do by itself. It's evidence in values and preferences. So, why not conduct randomized trials? These stories have told us we should be doing, if we want to know what's going on, we got to do randomized trials. So why not do randomized trials? Well, they're logistically difficult, and they're getting more so. I feel sorry for the young folks. When I was starting my career doing randomized trials, it was much easier than it is now. There's all sorts of barriers. P.J. Devereux, who I've already told you about, got a $40 million grant from the Canadian Institutes of Health Research to deal with that problem. And he's brought in some nice stuff, a national REB, that's going to help, and dealing with some of the logistic difficulties with contracts, which are a nightmare. So it's bad, but it's possible. So fortunately, a lot of the young folks haven't given up. They keep doing it, and we should be doing initiatives like P.J. Devereux is doing to make it more simple and less expensive. Yes, it's expensive, but what would be more expensive? To do the trials and then know what we should be doing, or not to do the trials and not know what we should be doing? It seems clear to me, if you did a cost analysis, and some people have done these, to know what's going on is going to, in the long run, so the trial's expensive. But the thousands or tens of thousands or hundreds of thousands of people that are going to benefit from the results of the trial, it's less expensive knowing what's going on than it isn't. And there's the ethics of randomizing when there's apparent benefit. But when is the evidence sufficient? So the cardiologists thought that there was sufficient evidence with those antiarrhythmics to give it out. Fortunately, there was enough hesitation that they did the trials, and they showed harm and mortality. We saw the antioxidant vitamins that seemed to be okay. Let's give out, and hormone replacement therapy, but turned out not to be. Okay, so we should be cautious about being sure, and thus the beta blockers is another example. Everybody thought they were beneficial. They weren't. So we have lots of examples where we should be skeptical. So we should set a high threshold for concluding that we don't need the randomized trials. All right. Clinical medicine, with all the talk about real-world evidence, fortunately, in clinical medicine, people still accept the need for randomized trials. And COVID has been, for the medical therapy, COVID has been a spectacular success of evidence-based medicine. So rapid production of the primary evidence, these innovative platform trials. Someone has already alluded to the UK model, where they've set up a system of getting all the hospitals on board, community hospitals, ready to do randomized trials. And as a result, within 2 years, we have 3 drugs that are effective for reducing mortality in non-severe COVID, and 3 classes, the 3 drugs listed there, and 3 classes of drugs for severe or critical, and they're listed there. We have lots of things that reduce mortality, and we got them fast. And not only did we get them fast, we summarized the evidence in systematic reviews very quickly, and we got them into clinical practice guidelines for use of clinicians very quickly. A triumph, in my view, of evidence-based medicine. On the other hand, what about all the public health interventions? Public health interventions, in contrast, were a mess. They were a mess from beginning to end. And as a result, while there is no tradition of randomized trials in the public health field, tradition of non-randomized trials, as Atla has told us, very few randomized trials of these public health interventions. And we need the randomized trials. Why do we need them? For exactly the same reasons that we need them for the traditional medical interventions. We need them because if we don't do them, we're going to get it wrong. we're going to be uncertain, and we're going to get it wrong. And the consequences for the public of our getting it wrong are bad. Okay, so we continually, within the public health area, we continually conduct observational studies, poorly designed and implemented. And I don't know if it was, I was recently asked, well, can we really experiment? Can we really experiment on people? My point is, we're experimenting anyway. When you one group closes the schools for this one, and another closes the schools for that, and a third closes for this. Some people lock down and some people don't lock down. These are experiments. They're just crummy experiments without, that don't yield any reasonable conclusions. So it's even within, we talked about small area variation. I practice at 2 different hospitals in Hamilton. At one of them, I had to wear a mask as soon as I came in the door. Down the road, I didn't have to wear a mask at all. Okay? You had China locking down, Sweden minimal restrictions. You have countries, states, provinces doing differences on whether they close the businesses or they don't close the businesses. Keeping everybody inside or not keeping everybody inside. Wearing masks and what kind of masks, as Mark told us about. Distancing, how much do you distance? And what my understanding is limited, but what I understand, the utter catastrophe of the school closures, which have resulted in big deficits in kids' education that are going to be permanent and that are particularly bad in low socioeconomic settings. So, what should we do, as Attila heroically tried to do? Failed, but maybe with this group, maybe the next time. I quite likely won't be around to see the next pandemic. Most of the people in this room will. You'll be here, it's going to happen. And hopefully this time you will make a difference so that we will be ready for it, so that we can organize for rapid cluster RCTs, just as we have done a great job, I think, of organizing for the rapid conduct of RCTs, the systematic review summarizing them, and the trustworthy practice guidelines that has led to the excellent medical management of people with COVID. And hopefully that will apply to the next pandemic. Thank you very much. That is what I have to say. Thank you, Attila, for the talk.